All right, with that being said, I would like to introduce our first speaker for today, Dr. Elizabeth Hale, who is going to give us an overview on skin cancer and talk to us about the importance of early detection and prevention. Dr. Hale is a clinical associate professor in the Ronald O. Perlman Department of Dermatology. Let's welcome Dr. Hale.
Good morning. Thanks for coming to our annual symposium on skin cancer. So I'm the first speaker, and I'm going to be speaking about early detection of skin cancer and how we can take some steps to prevent our chances of getting skin cancer. And then my colleagues will speak about the medical and surgical treatment of melanoma, which is the most serious type of skin cancer. Before we get started, this is the pre-questionnaire. What is the most common type of skin cancer diagnosed in the United States? Is it A, melanoma, B, squamous cell carcinoma, C, basal cell carcinoma, D, Merkel cell carcinoma, or E, metastases to the skin from other types of cancers? So I guess I'll just give a few seconds to vote now so we don't, usually I see a timer at the bottom, but. All right, I'm just gonna go ahead here. Sorry, if everyone can just make sure to vote. Just do it again, because I think I was supposed to advance it before, I'm sorry. Okay, so you'll have to listen to my talk, but the majority think that melanoma is the most common, and we will get to that soon. Basal cell is actually more common, melanoma is more serious. Which type of skin cancer is the leading cause of death among young women? Is it basal cell, dysplastic nevi, squamous cell, malignant melanoma, or lung cancer? I'm just going to do a few seconds so we can get on with the talk here. But yes, melanoma is a leading cause of death among young women. And then which of the following does not directly increase your chances for developing skin cancer? Is it high cholesterol, sunburns, tanning beds, cigarette smoking, and having atypical moles? So which does not directly increase your chance for developing skin cancer? And I'm just going to go ahead so we can get to the talks here. And correct, cholesterol does not directly increase your chance. The other ones do. Okay, so to talk with you about skin cancer today, I think it's important that everyone, including our students here, know that skin cancer is actually the most common form of cancer diagnosed in the United States. And it's thought that over 5 million new cases will be diagnosed in the United States this year. Interestingly, there will be more new cases of skin cancer than breast cancer, prostate cancer, lung cancer, and colon cancer all combined. And I think people think of those 4 cancers as fairly common, but skin cancer is more common than all of them put together. It's thought that 1 in 5 Americans will develop some form of skin cancer at some point in their lifetime. And this includes actually, Asian Americans, African Americans, Latino Americans. So when you're looking at a Caucasian with light skin and some significant sunburn history, their chances are dramatically higher. But 1 in 5, we're seeing it across all types of skin and all ethnicities. So everybody really should be familiar with what to look for. As we briefly talked about in the pre-quiz, the most common types of skin cancer are basal cell carcinoma, squamous cell carcinoma, and melanoma. The far and away most common are basal cell carcinoma. Again, fortunately, they're not as serious, and we'll talk to that. But about 80% of new skin cancers are basal cells, about 16% are squamous cell, and even less than 4% are thought to be melanoma. However, even though melanoma is only about 4% of skin cancers, it does account for over 75% of skin cancer-related death. So that's really important, and that's why the bulk of what we'll talk about today is melanoma, because it's the most serious type of skin cancer. But I'm first going to walk you through the other types. So when we talk about non-melanoma skin cancers, again, of the common 3, basal cell and squamous cell carcinoma are non-melanoma skin cancers. Those represent half of all cancers diagnosed in this country. It's thought that about half of all Americans who live to age 65 will have at least one of these skin cancers once. The good news is both basal cell carcinoma and squamous cell carcinoma have a better than 95% cure rate when they're detected and treated early. So basal and squamous cell carcinoma, they're less aggressive types of skin cancer than melanoma, But we still need to treat them because they can be highly disfiguring. Dr. Berman just showed me a picture of a large basal cell he treated this morning. I don't know if you're planning to share that. But so even though they're not as serious, they can be highly disfiguring if they're left untreated. As far as risk factors for basal and squamous cell carcinoma, cumulative sun exposure is a big risk factor. So basically, the more time that we spend in the sun, the higher our risk goes up for developing basal cell and squamous cell. They are more common as we get older, mostly because we accumulate more sun damage with age, although we're seeing more of these types of skin cancer in younger patients as well. Because they're related to sun exposure, they tend to occur more commonly on the sun-exposed areas like the chest, the head, the neck, the upper arms, the back of the hands. And even though we're seeing increases in all skin types, like I mentioned earlier, people with fair skin, with light eyes, with red hair, blonde hair, because they don't have as much protective melanin, they're at increased risk from sun damage and from basal and squamous cell carcinoma. So basal cell, as we refer to as BCC, again, it's the most common malignancy of all cancers. So it's the most common skin cancer, which makes it the most common cancer diagnosed in the United States. 80% of all non-melanoma skin cancers are basal cells. They're not very serious, thankfully. They're usually totally treatable, but they can be highly disfiguring because they have a propensity to invade local tissue if they're not adequately treated. And interestingly, the number of young women diagnosed with basal cell has more than doubled in the last 30 years. And we think some of this has to do with early exposure to sunlight and also indoor tanning beds, which have proven to be very dangerous and causing skin cancer. So as far as what basal cells look like, they sometimes look, we call them pearly papules, but they're basically kind of elevated, shiny growths on the skin. They oftentimes have an indentation in the center. And as they grow, we start to see little blood vessels called telangiectasias develop on the surface. So these are kind of like textbook basal cells, shiny, kind of pearly little bumps on the skin with little blood vessels. Oftentimes they present as like the pimple that doesn't go away. So some of my staff is here and they know that if someone has a pimple or a lesion on the face and I ask how long they've had that and they say, well, I've had this pimple for 2 months, it sometimes bleeds, that's often a good sign that maybe it's not a pimple, but that it could be a basal cell carcinoma. So any kind of non-healing wound on the skin should be seen and evaluated by a dermatologist for a skin biopsy to establish a diagnosis. Again, any kind of sore that's bleeding, you can see most of these pictures I'm showing you are on the head, the neck, on the sun-exposed areas, because basal cell carcinoma are very common in those areas. But even something like this that looks fairly innocuous, if that's persisting, again, a cut that doesn't heal or an acne lesion that doesn't go away, should probably be evaluated for a skin biopsy. I know these pictures are kind of not pleasant to look at, but I think it's important to see that if left untreated, basal cell carcinoma can be disfiguring and can cause local infiltration and damage. And I think this is important because sometimes patients come in with a little nothing and they ask, do I really need to have surgery for this? It's a little nothing on my face. But if they're left alone, they can progress and become disfiguring and cause major problems. So squamous cell carcinoma is the second most common type of skin cancer. This is the one that is correlated with chronic sun exposure as well, also with cigarette smoking. So if you think back to the question I asked, some people answered smoking is not correlated with skin cancer. It can be, particularly when we're talking about squamous cell cancer of the lower lip. If you think about it, the lower lip is exposed to the sun year-round. People who get sun exposure combined with cigarette smoke, both of those things can cause mutations that lead to skin cancer. Squamous cells also can occur in association with other things like chronic burn injuries, scarring, also the HPV virus, which is the virus that is known to cause warts, genital warts, and otherwise, has also been associated with squamous cell carcinoma. Unlike basal cell, which almost never metastasizes, not never, but virtually never, squamous cell carcinoma, if left untreated, does have moderate metastatic potential, leading to about 2,500 deaths per year, probably higher than that actually. So it's important, again, to try to treat these things while they're still early and confined to the skin. Squamous cell carcinoma presents a little bit differently from basal cell, although they both commonly occur on these chronically sun-exposed areas. Squamous cell in particular, you directly increase your chance of it the more time you spend outdoors and in the sun. And this is why they're so common on areas like the top of the ear, the lip, like I mentioned. These are areas that are exposed to the sun every single day, so it's not enough to just think about sunscreen when you're going to the beach in the summertime, but really to think about applying it every day, because areas like the ears, the lips, the backs of the hands, another big one, are associated with squamous cell carcinoma development. These often present kind of warty. This is because squamous cell carcinoma starts on the outermost layer of the skin, and these mutations cause the skin to start turning over very rapidly. That's what cancer cells tend to do. But because they're at the outwardmost portion of the skin, that results clinically in a scaly area. So they're oftentimes thick scale, they look kind of warty. We call them hyperkeratotic because they're so thick and scaly. And oftentimes they do tend to bleed as well. Sometimes they look, we call these cutaneous horns. They actually can look like little horns coming off the skin. And again, that's because the outermost layer of the epidermis is proliferating so rapidly, which is resulting in chronic thickened scale. So this is how squamous cell cancer often presents. Sometimes they're less well defined, but again, the lower lip is a very common area for squamous cell, and it can sometimes start as like an ill-defined scaling patch of skin that doesn't heal. Again, any sort of non-healing sore should encourage someone to see a dermatologist to have a biopsy of that lesion. And again, like basal cell, these things often start in the skin pretty small, but if they're not treated, they can present and progress, and they can present like this, kind of disfiguring, bleeding, infected. So it's a good thing to get these things treated while they're still small. So the last skin cancer I'm going to talk about is malignant melanoma. Again, it is the least common of the three big ones, basal cell, squamous cell, and melanoma. So far and away the least common, but the most serious. And my colleagues will talk about treatment of advanced melanoma after this part of the talk. So the incidence of melanoma is increasing dramatically in the United States. It's thought that the incidence has increased about 700% over the past 50 years. For example, in the 1930s, it was thought that 1 in 2,500 Americans would get melanoma, and in 2015, it was thought that 1 in 50 Americans, and that number continues to increase. It's thought to be the 6th most common cancer in the United States, but interestingly, of the 7 most common cancers, it's the only one whose incidence continues to increase. Part of that is because we're getting better at diagnosing them, so we're diagnosing more melanomas, but much of that is actually a true increasing incidence. And again, as the ozone layer starts to decrease and as people continue to spend more time in the sun and in tanning beds despite knowing their risks, we're still seeing this number go up. So we're really trying to educate people about the importance of sunscreen, which I'll get to. Some interesting thing about the epidemiology of melanoma is that it's extremely common in young women, but after about age 39, the incidence shifts over and it becomes more common in men. So after age 40, melanoma incidence in men surpasses that in women, and that trend continues. It's thought in this country 1 person dies from melanoma every hour. Like I mentioned earlier, it is a leading cause of cancer-related death in young women. But after those incident curves cross over, actually older Caucasian males have the highest mortality rate. And it's thought that men may not be as good about coming into a dermatologist to get checked, and by the time their melanomas are diagnosed, they might be at a more advanced stage. So we like to encourage everyone, man or woman, regardless of your skin type, to have an annual skin examination. Fortunately, even though melanoma is so serious, if it's caught early, it's almost always curable. So there is a 99% 5-year survival rate if they're diagnosed and treated before they have potential to spread throughout the body. And I just wanted to go through how to diagnose melanoma. We talk about the A, B, C, D, E's. A is for asymmetry. So usually benign moles on the skin tend to be very symmetrical, very even, very regular. But many forms of melanoma are not symmetrical. So if you draw a line down the middle of a lesion, you don't create matching halves. Along these lines also, B is for border irregularity. So although there are some exceptions, usually benign moles tend to have pretty even borders. They tend to be round or oval. And when you start to see jagged borders or scalloped borders or notched edges, these are signs that maybe this could be a melanoma or a lesion that's progressing to melanoma. C is color variability. Again, usually benign moles are pretty homogeneous in pigmentation. They tend to be light brown, medium brown, dark brown, but pretty uniform. but if you start to see various colors within a mole, that could be a sign that this is not a regular mole, but could be an atypical mole progressing to a melanoma, and this here is a more advanced melanoma. You can see black, but also red or white or even blue, and those are ominous signs that the melanoma could be advancing. D is diameter. Unfortunately, I updated this talk that I saved in the wrong version last night, but I do want to mention there is a dermatologist in Georgia by the name of Dr. Goldsmith who has come up with D for darkness. I just want to mention this because for years, since the 70s, we've talked about D as diameter, and we used to say that melanomas tend to be larger than 6 millimeters or the size of a pencil eraser. Now we've gotten much better as dermatologists at diagnosing smaller melanomas. Many times we'll use like a pocket dermatoscope, which is a magnifier, to help us see features in smaller lesions. So there's a move, at least in the state of Georgia, that's spreading now, that maybe D, darkness might be replacing diameter. Because sometimes if someone has light moles and there's one that's jet black and really stands out, even if it's small, like 2 millimeters, that could potentially be a melanoma. But the most important one of the acronym, I think, is E, which is evolution or change. And I think, and again, my staff can support this, but if someone with a lot of moles comes in and they say, of all my moles, like this one is recently changing, even if it's not perceptible to me yet, patients often know if something's not right with their moles, which is why we encourage people to familiarize themselves with their moles. But if a mole is changing, either if the patient notices that or if we notice it, this is an example of one of those dermoscopic images I was alluding to. So we'll use like a handheld magnifier, and we'll sometimes see these subtle, you can see that this is not a symmetric mole, and the borders are not regular, and these signs of change can definitely show that a lesion has become a melanoma. I just want to talk about some various subtypes that don't necessarily fit these rules. This is a type of melanoma called nodular melanoma. They tend to be uniform, but as you can see, they are jet black. So even though they might have smooth edges and they might be all one color, when you see a new black nodule like this on the skin, it often portends a bad prognosis because this type of melanoma that is very dark and grows quickly often quickly invades and develops potential to spread throughout the body. I do want to point out a type called acral lentiginous melanoma, a type of melanoma that occurs on the soles of the feet, and patients with darker skin tend to be at a higher risk for this type of melanoma, and they tend to be diagnosed later at a more advanced stage when they also have potential to already spread throughout the body. So this is why when someone comes in for a full skin check, we always check the bottom of their feet, in between the toes, etc. And then these are pictures of more advanced melanoma. I think you can tell that these do not look like common benign moles. They don't follow any of the rules, and these can be very serious. So as far as risk factors for melanoma, some of them are similar to the ones we talked about as for basal and squamous cell carcinoma, in that people who have not a lot of melanin, so people with light skin, light hair, and light eyes, and especially those with a personal or a family history of melanoma, are at high risk because there is a genetic component as well as the environmental component or sun exposure. Interestingly, with melanoma, though, we talked about basal and squamous cell carcinoma, how it's sort of cumulative sun exposure. People live longer, they get more sun exposure, they're higher risk. Melanoma, we talked being very common in young women, and that's because younger individuals sometimes get this intermittent, intense sun exposure. We call it sunbursting. So instead of like chronic spending time in Florida at the beach, these people oftentimes live and work in a place like New York and then maybe go to the Caribbean 1 or 2 weeks a year and just fry themselves, or they go to an indoor tanning bed and fry themselves. And that type of mutation is very dangerous and leads to the development of melanoma. So it's more like this intense short burst of sun. Two other specific risk factors for melanoma. One is having numerous moles, and especially atypical moles, which I'll show you a picture of. And the other one that I've alluded to is the use of artificial tanning devices, which prove to be even more dangerous than sun exposure. But this is just a picture from the web of someone with a lot of atypical moles. I see patients like this in my office every day, and pictures are very helpful to follow these patients. They can be done professionally. They can also, we take them with the iPad as part of our medical record now. But patients with moles like this are at higher risk of developing melanoma, both in a pre-existing mole, so moles can actually turn into melanoma, but they're also at a higher risk in their normal skin. So these patients need to be checked very regularly, at least twice a year, and sometimes 3 or 4 times, depending on their risks. Other risk factors, sunburning. Again, sunburns are like that intense short burst of sun exposure we talked about. It's thought that 5 or more sunburns at any age doubles your risk for melanoma, but even one blistering sunburn during childhood or adolescence doubles your risk for melanoma later in life. So it's important when I first meet a patient, I ask them about their tanning history, if they had sunburns, if they use indoor tanning beds, because those patients are higher risk. Again, the first exposure to tanning beds in youth increases the chance of melanoma by 75%, which is huge. So what can you do to protect yourself in conclusion here? So this one is really important. Contrary to popular belief, only about 25% of a person's lifetime sun exposure is acquired before age 18. So I hear all the time patients come in, oh, it's too late, I used to lie out, I used to sunburn, but it's definitely not too late. Studies have been done that even if you don't start using sunscreen on a regular basis until adulthood, even until your 50s and 60s, that will decrease your chance of developing melanoma later in life, and also makes your skin age better and stay looking younger. So we try to encourage people to wear sunscreen every day. You want to avoid the peak hours of sunlight when the sun's rays are the strongest. So if you're a runner, for example, it's better to run maybe early or in the morning or later in the day. Wear a daily sunscreen. Again, we like to recommend SPF 30 or higher to all of your exposed areas. So I personally, even a day like today, I actually put on sunscreen this morning. I don't do it on my body that's covered, but on my face. I know the students here think I'm crazy, but I do, because studies have confirmed the fact that wearing it every day decreases your chance of getting skin cancer. It also lowers your development of wrinkles, of brown spots, all the other things people come in that they want to get rid of. So wearing sunscreen when you're young is very important to keep your skin healthy. Also wearing protective clothing. I'm a big fan of sunscreen, but I've started even exercising in long sleeve sun protective shirts. I'm training for my 7th marathon now, and I run in long sleeves. I know, again, crazy, but you get used to it, and it's really a great way to protect yourself. I even updated my pictures last night, and they didn't save in this new version, but these are my kids, and teaching them to embrace applying sunscreen, teaching them sun protection early. This is when they're younger. My boys are now 14 and 12, and when I ask them to put on their bathing suit, most of the time they come down wearing a rash guard as well, which makes me happy. So you want to teach them good habits when they're young, and you want to avoid tanning salons and tell your friends and family and people you know to stay out of tanning salons. Indoor tanning lamps emit doses of ultraviolet radiation that can be 12 times more powerful and more dangerous than the sun. Again, it's recognized as a human carcinogen, increases our chance of melanoma by 75% if we go to indoor tanning beds before age 35. So for people who still like to look tan, I like to say that sunless tanners are a safer option. Vitamin D is this controversial. People think they need to be in the sun for vitamin D production. Actually, our receptors in our skin get saturated very quickly, and a safer way to get vitamin D is through the diet, eating foods like salmon, vitamin D fortified cereals, milks, and examine your skin regularly, because I think it's really helpful to be familiar with your own moles. So if you notice a new spot that looks concerning, or a spot that's changing, or a pimple that doesn't go away, cut that doesn't heal, you should go in and see a dermatologist, because skin cancer is so common. It's largely preventable, but it also can be curable when it's caught early. So I thank you for your attention, and now I'll turn over to Dr. Berman, who will talk about surgical treatment of melanoma. Thanks for your attention.